Good afternoon, Sam, Nancy, Raj. Who else do we have?
Good afternoon.
Hi.
Sean, hey, thanks for joining us. Raj, Stephen, good to see
Hi,
you.
how are you?
Hello, everyone.
I have to look again at your paper that was heavily quoted today, this morning, Steve, on AI and spirometry.
Hi, Jim. I'm here now.
How you doing?
Hear me?
Oh, who else do we have? Okay. Oh, okay. Hey, hi, George, Rick, Raul. Is everybody recovering well, Raul?
Yes, everybody's good. Yeah.
Okay, great. George and Javier, great sessions just this morning. Jerry Kreiner did a great job. That was a lot of fun.
Yeah, no,
Ricardo,
he's really good.
yeah. Mario, buongiorno. Rick, I understand you had a good breakout.
Yes, we did. We're ready to change the world.
It's about gall darn time. We want to stop having the pulmonologist have to apologize to the cardiologist. I've heard that for years now. Pulmonologist uber alles. Okay. Do we have? Al. Okay. Well, do you guys, Rick, you and Raul, you ready to go?
I think so. I don't see Raul. Where is Raul?
Yeah, I'm here.
He's right next to you.
You don't have me in your friend list.
All right.
I feel hurt now.
No,
Okay.
So Rick, we've had a great time. Some really important things, and we're looking forward to you guys setting the bar even higher.
We'll do our best.
Thank
All
you.
right. So here we go. We're in session 5, the COPD and small lung nodule technical applications again session. And Raul and I will be co-chairs and moderators on this. The way we split this up is the first half of this session is going to be dedicated to the topic of improving the impact of the KIBA CT small lung nodule profile. The second half will be making progress toward a COPD and small lung nodule protocol. And so for this first half, I will be giving an overview presentation. We're very fortunate to have Nancy Obuchowski from the Cleveland Clinic, who's been just a critical statistician helping out the KIBA small lung nodule profile and many other projects. We also have Raj Subramaniam. He's the chief of medical physics at the Icahn School of Medicine at Mount Sinai. He's been deeply involved in lung aspects of CT scanning and many other things, and particularly with phantoms. And we also have Sam Armato from the University of Chicago. And Sam, I guess we could call you a veteran of computer-aided detection and medical physics. And then we have Stephen Lamb from the British Columbia Cancer Agency and the Pan-Canadian Lung Cancer Screening Network. Do I see Stephen? I don't know. Maybe we don't have him yet.
He's back. He's back.
He's here.
Okay, good. Stephen has just been just a real leader in establishing protocols and standards and publishing around lung cancer screening in Canada, and also very influential with collaboration with Australia. So we have a great panel. I think probably best thing to do is for me to just jump into an initial presentation about the KIBA small lung nodule profile, and then we'll have each of the panelists make perhaps a statement or a small presentation. So So we'll just dive in. Any you want to add anything, Raul?
No, go ahead, Rick. Thank you everyone for joining, and I think it's exciting that we're talking about the practicalities of this, no? Now that we established the need.
Great. Okay, so I'm going to share my screen. You get to see my nice messy desktop, but also a presentation. There we go. All right. So I'm not sure if everyone's familiar with the KIBA small lung nodule profile, but KIBA stands for the Quantitative Imaging Biomarkers Alliance, and it's been around for over 10 years, establishing what are called profiles, or if you will, documents that describe how to obtain high precision, low bias, highly accurate quantitative measurements. And that involves, many requirements that must be met for different quantitative applications. There's a CT small lung nodule profile, which we'll talk about today, but there's also a lung density profile, and both of which are moving nicely within the KIBA framework. So I'm just going to take you back in time to 2010. The reason why we're doing this is because way back when, and you guys have seen, many of you have seen this, but for those who haven't, we decided to put phantoms on the chest of patients in a phase 2 clinical trial run by Roche. It was called the Abigail study. Long story short, we saw 1.6 centimeter sphere change in size by 44%, or in this case on the bottom, 33%. And it was with the same model scanner at different places around the Eastern Europe. We also replicated it in the US on the same type of scanner. And we realized, boy, I wasn't expecting, personally wasn't expecting changes of this magnitude in CT scans, but there they were. And what happened was, just to compress this down, was that when CT scanners switched from step and shoot to helical scanning, certain methods were employed on some scanners, and it resulted in this type of a spatial warping artifact. It's literally changing the size of these objects by a major amount. And this was unknown at the time, and it took us until 2016 to get this published to prove to everybody this was happening. And we got started saying, oh, well, how much of our other assumptions about CT are correct? And ultimately, when we're talking about detection of and measurement of very small lung nodules, unfortunately, with a 6 millimeter lung nodule, which is kind of shown here as an ellipsoid with a synthetic ellipsoid, we're operating with 6 to 9 pixels in a single CT axial image. And it does not take much if you're just measuring with maximum diameter, it does not take much to cause a 59%, a 1 millimeter change in volume can be a 60% change. I'm sorry, 1 millimeter change in diameter can be a 60% change in volume. So if you're looking for changes in objects this small, is this growing, is this shrinking? You really have to have much more careful control of the scanner. We can't have the types of things that I mentioned to you earlier. And this is an example that David Yankelevitz got. He was asked to biopsy a case, and they said it was growing from time 1 to time 2. And it turned out to be on that scanner that we mentioned to you earlier. So they didn't do the biopsy because it was an artifact. This is not a true growth. Even though it looks like it. So basically what this boils down to is that precise use of precise and quality controlled imaging tools is critical. And we can certainly eliminate this kind of thing and many other things that we've discovered over the years by using careful quality controlled phantoms and tools. So if you look at if you go find the KIBA small lung nodule profile, you'll see it's a fairly long document. I think it's over 40 40 pages. But what it boils down to from a sort of an imaging, optics, and physics point of view is a series of fundamental properties. The resolution has to be within a certain range. The aspect ratio between resolution and the Z dimension versus X dimension can't exceed a certain amount. And all the usual suspects are here. You know, bias in Hounsfield units is there, noise, edge enhancement, edge enhancing recon kernels. We can only tolerate a certain amount of edge enhancement, or we can't actually measure resolution very well. And then there's our famous spatial warping, which we quantified here. So we've gone to the trouble, many of us over this last decade, coming up with these methods and validating them. And we have a phantom now that is the only phantom that I'm aware of that can measure these things, these really important items, at a distance of not just the center of the scanner, but also out to 200 millimeters. So the reason why that's important is because a lung nodule can, actually 60% of lung nodules show up in the periphery. So if you're not measuring resolution far out, like at about 160 millimeters for a large patient, you aren't really establishing whether the resolution is in the right range. So, but we don't want to tell a whole bunch of community hospitals to go, you know, basically take a bunch of measurements and try and, you know, use Excel to figure this out or other things. What we did was we created well, first of all, it's a low cost phantom. It's $250, making it accessible to community hospitals. We basically said, look, you can scan this in between patients within 5 minutes. It requires that you all already passing the ACR phantom assessments, ACR accreditation phantom, and manufacturer phantoms as they require. But on top of that, we're basically saying if you want to measure small lung nodules with high precision, you're going to need to do this and upload it to a cloud, and you get back a report within 5 minutes typically. And then we can tell you not only what to do if you see an error here, but also whether there's sites around the world that have gotten better performance on your scanner. So this is really exciting, because now we have a really fast and easy way to tell people whether or not they're within spec of doing very high quality CT lung measurements. And I really, I can't thank the Prevent Cancer Foundation enough for the couple grants that were given to both RSNA, KIBA, and Acumetra. That's who I represent. But as a result of that, we were able to put 80 phantoms around the world, and we've also put another 20 out there as well. So we now have 100 of these phantoms distributed, and we have 2 locations for basically, these are the locations of the servers on the cloud, and we're serving up a global image quality assessment, and even you know, through crowdsourcing, optimization of scanners all over the world. In fact, this morning, some scans were submitted. Fortunately, they were passing. And it's just a great thing to see, to have a global infrastructure built with really the help of KIBA, with Prevent Cancer Foundation, and of course, all of these sites who are contributing massive amounts of data to this effort. So what does this mean? What happened when we deployed this? Well, we concluded a study in March of 2019. And what we found was when the sites, when they first started using the Phantom, 37% of them were passing. In other words, they passed all the requirements that we mentioned, just the image quality requirements. And when they were done, when they put their last protocol through the system and scan of the Phantom through the system, we got up to 60%. Now we made some changes to the profile since then, and we feel that that number is going to be more like 75%. So we can take, we think we have initial preliminary evidence that we could take a global population of lung cancer screening sites that are operating around 30% adherence to a requirement like this, and bring them up to around 75%. And that, I think, is an exciting thing. Now we want to show how much difference that will will cause in ability to eliminate false positives and false negatives and all those sorts of things. But that's our initial result. And we do have a second Phantom coming online, which we're about to ship to Poland. We're going to ship 16 Phantoms to the lung cancer screening effort in Poland, thanks to Dr. Witold Wiseman. And we have many other sites that are planning to use these. So we're trying to get these out by the end of the year. This is a much bigger and more involved Phantom, so it's quite a job, and COVID has not helped us in any way. So massive amount of data here. We have. I also want to thank the different groups around the world who've used the Phantom and either given presentations or published. First is the FDA. They've scanned the Phantom numerous times, and they're one of the, when they use it a lot. We also have colleagues in the NHS who've used it and gotten some really interesting results with their scanners. And then I just want to mention this recent publication from Dr. Stephen Lamb and his colleagues in Canada. They put together this really nice, basically publication that gives guidance on management of lung nodule, screen detected lung nodules. And they refer to the KIBA small lung nodule profile as well. So we're gaining some steam here and a lot of activity going on. One of the things that this kind of set the stage for was that when COVID hit, the two KIBA groups I mentioned, the small lung nodule profile and the lung density profile, got together and we said, well, let's put together some recommendations for sites around the world who are scanning for COVID and quantitative analysis of COVID. And let's leverage the information that we've gained, both profiles. And one of the really nice outputs of this is that we came together and formed a table. Now, this is based on a massive amount of data, not just the data of the Phantom that I mentioned, but other groups, and also feedback from the manufacturers. And now what we're saying is, if you're going to do quantitative assessment of COVID in CT scans, we're guiding the community to basically use these recon kernels, because these have been established to have high quality for quantitative purposes. And obviously there's been not a lot of research on COVID before we put this together, but we're still feeling really good about this being a good initial recommendation. And now this is not published yet. We're still in the works. It's still in the works to get this published, but it should hopefully be published soon. And then lastly, really relevance to this workshop is that we're planning to prepare similar guidance, a guidance document for combined CT lung screening and COPD imaging, and leveraging the tools and the methods and the data that has been collected over many years in many groups to at least get on paper what would be a good starting protocol for both of them on the major manufacturers. So that's really exciting, and looking forward to that. So the question of this panel is, how should we now take this profile and improve upon it? And I just want to point to you one thing we did. We basically added some ellipsoids to this Phantom, this basic Phantom. These are, you can see them down here. And one of our members, actually David Gerada, basically went and measured different software, major software. And the problem is that the bias values, I shouldn't have circled this one, I should have circled this one. The bias value is exceeding 5%, which is our limit. And this is a real problem. We only allowed for 5%, and the software is proving to have worse than 5% for very small lung nodules, because it's very challenging. So this is the first thing I think that we have to address, and we'll hear from the panel what they think. But to me, this is a major issue. We need to better understand the bias and the precision from a metrology point of view and to give out good guidance. And Nancy was going to help us basically navigate through this minefield of issues that happens when you start to measure things you didn't measure before. So that's one. The next one is we feel clinical sites have a lot of pain when we tell them use the same scanner at time 1 and time 2. So the question is, if we can give sites guidance, not just for when a scanner is passing, but when 2 scanners are within the same image quality metrics. So in other words, they can be used at time 1 or time 2, depending on availability. We can help clinical sites maintain good high image quality and also utilize their equipment better. This is resolution, which is better when you get smaller, a smaller point spread function. And this is distance out from isocenter. So you can see here that 3 different scanners had 3 different profiles in terms of resolution versus distance from isocenter. And this is noise. And so what we want to do is say, well, when can you know, how close do these have to be before you can use the same, either scanner at different time points? Now, this is really exciting because this is one of the community hospitals that got one of those phantoms, and they scanned it for 1.5 years every quarter. And they really 2 remarkable things here. First is the stability of that scanner and the high performance of that scanner across all of these metrics. And the reason why you see these different colors is because those are different distances from isocenter. So imagine you're a patient and you're being scanned at somewhere twice, 2 times in between in this interval. You'd want to see a chart like this. I mean, you want to believe that there's a chart like this showing that everything was stable, because if these numbers jump all over the place, your lung nodule measurement can also vary a bit. So what this also shows, this is a great scanner and also a really stable quantitative phantom that's giving really high quality results. These are all independent measurements, so it's really very good. Now, one of the problems with this is that well, what if you pass, but you vary as you pass? So imagine all these curves have huge variation in them. Right now, the KIBA small lung nodule profile will tell you you've passed and you're fine. So the second area we're considering or proposing to make changes is that we create some form of stability on these requirement on these measurements. And that's a second area that we're considering. The third is we have a CTLX2 phantom, which is a much bigger phantom. It allows us to put water all around a big phantom, similar to what our previous phantom had. And it allows us to put additional objects inside of the phantom with ports. And we did some scanning at Mount Sinai. Raj Subramaniam was involved with that. And we have some initial data that I don't have time to show, but it shows that we have basically similar measurements between this phantom and the previous CTLX1 phantom. So it's important that we continue to do these studies, and the question here is whether to add this and how much to rely on this. For the KIBA small lung nodule profile, it would allow us to start to look at dose versus image quality analyses. How far can you drive dose down and still maintain good image quality? And then lastly, for the major recommendation, major protocol changes, we have done work in the past on a table phantom. The idea is to be able to measure all the things that you saw before, but to insert it literally on the table, and then every patient that comes in would basically have this type of information. You can see it here embedded in the CT scan, and we could automatically monitor that, measure that, and notify the tech if, for instance, a lung nodule has too much noise, or if there's something going on that would really hurt our measurement of it. So this would be real-time monitoring, quality control of CT scans while patients even on the table. So these are the list I just mentioned here to you. I'll add an additional one, a sixth one. Right now, the small lung nodule profile only supports solid lung nodules. Now we're considering adding part solid. Some would say even non-solid, but part solid is the proposal here, and I'm sure there are other candidates. So that's the presentation. Thank you. So with that, I think it's important now to hear from the panelists. They've had a chance to think about these issues. And I'd like to start turning it over to Nancy Obuchowski at the Cleveland Clinic.
Thank you, Rick. You can bring up my slides, please. And you can go right to the second one, please. So I think the first issue that Rick raised was resolving the large software bias measurement. And so I'm a statistician, and I've been working in this area for a long time. But from a statistical perspective, bias is not much of a problem. If you can tell me the bias of a scanner, and you can give me a good estimate of it, then in my mind, it's straightforward to correct the scanner's measurement for the bias. And I can estimate change over time, even if two different scanners were used at baseline and follow-up, as long as I know what that bias was for each of the two scanners. Next slide, please. But what we can't correct for is a large amount of imprecision. So in my mind, repeatability is really the key, and we should spend all of our effort, not all of it, most of our effort into improving repeatability. We do need to know the bias, but we can correct for that, but we got to have good precision if we want to particularly estimate change over time. That precision is really key to that. Next slide, please. So often people ask me, will these KIBA profiles make a difference? And so I just want to spend a couple of minutes addressing that. So we spend a lot of time in KIBA talking about the technical performance of the biomarkers. And of course, that is absolutely vital. We need to know the bias, and we need to take lots of steps to make sure we improve the precision and get it as high, the precision as high as we can. But after that, where do we go from there? What's the next steps? So if you go to the last slide, please. So in kind of like a broad stroke, this is kind of how I see where these biomarkers go. After we have strong technical performance studies, we need to look to retrospective studies showing strong clinical correlation of the biomarkers to patient outcomes. And again, these are retrospective studies. We need to have that base before we can put a biomarker into a clinical trial. And then the clinical trial course is, first we take the biomarker and treat it as an integrated biomarker in the trial, which means that it's used as like a secondary analysis, not as a primary analysis. And we measure it there and see its performance. And then after we've successfully shown it's worthwhile, then we treat it and use it as an integral biomarker in a clinical trial. Now, lots of times people say, well, do we need to do a study that compares patients' outcomes with the profile versus the old way of making the measurements? And I don't think that that is needed, particularly at the last two levels, integrated and integral trials. I think it's interesting to do in retrospective studies to see what the difference would be. But I think once you've shown that your profile leads to better precision than not having the profile, then that is really key. And so I think launching into the trials with the profile is very important and relevant to do. Thank you. That's the end of my presentation.
Well, thank you, Nancy. Next up, we have Raj Subramaniam at the Icahn School of Medicine at Mount Sinai.
Thank you, Rick. I can have my slide. Thank you. I am a chief medical physicist in radiology at Mount Sinai. Mount Sinai, as you know, is a large network of hospitals, and we do have several CT scanners that are accredited for lung cancer screening with the American College of Radiology, which is the ACR accreditation. So ACR accreditation, as you know, is a two-step process where for accreditation, they evaluate not only the patient images, but also look at phantom image quality. Shown here are the modules that are evaluated for different image quality parameters. But I should say that most of it is qualitative measurement of image quality. Next slide, please. Once a site gets ACR accredited, you can apply for lung cancer screening accreditation, where mainly the protocol that is used is evaluated for technical specification. The most important of which are highlighted in bold here, like usage of multi-detector CT, the minimum slice width that we need to use. Next slide, please. As well as the most critical, which is the dose, where the ctDNA volume for a standard size patient should be less than or equal to 3 milligray. So once a site is accredited, how do we maintain or how do we monitor the dose? Next slide, please. For that, at our facility, we do have an active dose monitoring software, which is going to give us an alert if there is a dose threshold that is exceeded for a specific protocol. So we do set these thresholds for all the protocols that are clinically used. And so this has really helped us from a physics perspective to keep an active dialogue going with the clinicians as well as technologists. This has helped us to modify protocols by having conversation with the radiologist. And every day we exchange communication with the technical staff. If a threshold is exceeded, either because a wrong protocol is used, for example, using a routine chest protocol instead of screening protocol, because these two have different thresholds, and we are able to catch it at the back end and give a feedback. Okay, so this is a very active clinical tool that is available for physicists. Next slide, please. But I think the end goal should be to custom protocols, not only based on dose, but also image quality parameter, so that we are able to use the most appropriate protocol, not only based on low dose, but as well as the image quality end goal that is designed clinically. So in a way, as far as lung cancer screening, the CTLX-1 Phantom, which I had the privilege of working with Rick, has been able to give us a lot of data towards looking at image quality goals specific to the KIBA profile. And I'm looking forward to working with Rick on the next edition, which is the LX2 Phantom. And hopefully in the future meetings, we'll be able to share those data with you. Thank you.
Oh, thank you, Raj. So next up, we have Sam Armato from University of Chicago.
Great. Thank you very much, Rick. It's a pleasure to be here. Thanks for inviting me. If I could have my first slide, please. Great, thanks. And the next slide. So I wanted to pick up on one comment that Rick made, a very short statement to make with my part of the presentation. He talked about image quality stability. And I wanted to emphasize the fact that this is really an important aspect of anything we want to do with regard to computationally analyzing images for any clinical purpose. And I think it's that consistency from time point to time point. We talked about across scanners, but even within scanners, as time goes by, things may shift with the parameters that get used. Things may shift within the machine and the software itself. And I think that paying attention to that consistency of image stability quality is really very important. Measurements across scans to represent change in tumor size, for example, require that consistency. It's required to make the measurement process more reliable, both in terms of bias and repeatability, and we need consistency in the actual image acquisition process itself. Next slide, please. By fully considering image quality, always having that on our mind when we acquire clinical scans, whether it's for immediate clinical use to evaluate patients or with the potential for downstream further analysis, we want to make sure that that image quality consistency is there. It will facilitate compliance with the profile we've been talking about, the small lung nodule profile. And in fact, any profile coming out of KIBA requires this kind of consistency. It will also allow the most meaningful implementation of the profile if we've got that consistent image quality from time point to time point. And it also, I guess the next point, the next level I want to take this to is the idea that that consistency will enable quantitative imaging beyond just metrics of lesion size. And with the next slide, I'll show some results from my lab. This is the results of one scanner making multiple images of a single cadaveric liver phantom. And so the same object, same scanner, but we used a variety of different image acquisition protocols to make these variety of images. And this plot is showing the percent of features, radiomics features, texture features that are significantly different between the different image acquisition parameters used to acquire these images across different categories of features: Laws filters, Fourier filters, fractal features, gray level co-occurrence matrix filters, and first order histogram-based features. And this is all, we chose one specific set of image acquisition parameters, use that as the reference set, and the other indicated changes along the x-axis are then compared to the textures computed from the reference scan. So we see some dramatic differences. These are significant differences statistically across these features. So I bring this up to really hone in on the point that Rick made about consistency of image quality. Not only is it useful for the small lung nodule profile, but it's also useful for any other radiomics or texture-based analysis we may want to do with those images in the future. So with that, I'll conclude my statements. Thanks, Rick.
Great, thanks, Sam. So next we have Stephen Lamb from University of British Columbia.
Thank you, Rick. Can I have my slide put up, please? Just the next slide, please. So I'm a pulmonologist. I'm just going to approach these issues from a user's point of view. When we receive a CT scan for screening, we have to make one of three decisions: whether we recommend a surveillance rescreening that can be annual or biannual, or we can recommend an early recall imaging study, or we have to ask the patient to be referred for a diagnostic workup. So I just want to use the Nelson, EU Nelson protocol as an example, where they use 100 and 200 and 300 cubic millimeter as cut points for making these decisions. So on top with the little blue dots are the actual nodule volume from the Pan-Canadian screening study, showing nodules that are less than 600 cubic millimeter. So essentially about a quarter of the nodules that were found to be malignant on their first scan or on subsequent verification on follow-up are less than 300 millimeter. So if you look at the 300 millimeter cut point, for every nodule that is malignant, there are 26 benign nodules. If you use the 100 millimeter cut point, the ratio is 90 benign nodule to 1. If you use the coefficient of variation to look at these nodules. So we can see that we can both overcall or undercall what we recommend, and they have consequence in terms of delaying a diagnosis or causing potential harms from unnecessary repeat imaging studies or biopsies. Next slide, please. So to improve the impact of the quantitative measurement, like using the KIBA profile, I believe that we have to embed these recommendations into the guidelines, as we have done in the Canadian guidance document, where we emphasize the importance of using a standardized phantom for benchmarking CT software, post-processing and data analysis, and also think about the coefficient of variation in the measurement in terms of deciding on management. So lung rats, I just use this for the growth criteria as an example. For volumetric measurement, it does recommend using the KIBA profile the calculator, but for mean diameter, we still recommend using 1.5 millimeter or greater as a definition for growth. So it may actually give people the false impression that the mean diameter measurement can be more robust than volumetric measurement. And the EU Nelson protocol just showed the growth criteria. They actually don't stress the importance of a measurement variation. Next slide, please. So I think in order to demonstrate the impact of this precision quantitative measurement, I think we're to show that it makes a difference in personalizing the repeat screening interval or ascertain the urgency for diagnostic investigation. So I used the study that we did with Peng Wang in Johns Hopkins. They're using university available nodule and non-nodule features without using any CAT, just human reading. Using a deep learning tool, we can actually identify 10% of the screening population who might benefit from a prompt diagnostic workup for biologically aggressive tumor, and 55% of individuals with very low 2-year risk for malignant disease who could safely undergo the next scheduled screening CT in about 2 years instead of annually. So this leads to my final point. Next slide, please. I think the added value of this precision measurement driven applications need to be compared head to head with or without this kind of precision tools. But we need to use quality indicators to do the comparison. So for example, the appropriateness of early recall CT or PET CT imaging, what is the biopsy rate if you use one method versus the other, the number of invasive procedures for benign disease, the cancer detection rate, how many cancers we miss, the interval cancers with whatever protocol or method we use for measurement. So I think I will stop here and turn back to Rick.
Okay. Well, thank you, Stephen, and again to all of the panelists. We have a little bit more time, and we can now just move to questions. So Raul, you've been hearing all this. Do you want to start off with a question, or do you want to go to an audience? Or
we don't have anything from the audience. I guess. Oh, sorry, let me put my camera. I mean, I think, you know, one primary question is that when we're talking about, you know, the lung nodule profile, you know, the one of the advantages is you have a very concrete, very especially localized, you know, entity that is what you are trying to assess. And I think the phantom you had been describing this, that is fantastic to see that, you know, there is sort of the possibility of having sort of a qualification mechanism that is automated. But the phantom is definitely targeting that, is this the localized nature of this. I wonder if that is, you know, the fact that this is a very localized target somehow prevents the application, no, or the conclusions that you achieve to be extended to other quantities. And I think we will discuss this hopefully later on in the session. But it would be great to hear the thoughts of this panel around. Do you think this is limiting a little bit the scope of application, just due to the nature of the entity that you are trying to measure and to assess?
Does anybody want to take that? You're asking whether the locality of measurement is limiting us?
Yes.
Sam?
Yeah, I mean, I would say that's a good question. I do think that the Phantom, the CTLX-1 Phantom, it wasn't designed specifically for small lung nodules. I think it was designed, and it's been very effective with our, the computations we've seen, the data we've seen, at analyzing CT scanner image quality across a broad range of parameters. And I think when it comes to defining a profile for a specific disease, that's where we would get into the needs clinically for image acquisition parameters that give rise to the ability to most effectively identify or measure or assess that specific disease. But the Phantom itself is an overall assessment of scanner quality that can then be used as needed for specific clinical tasks, the way I see it.
I think we have a question from David Yankelevitz. Can we turn on David's microphone, or do we have to read it?
You have two questions from me.
Okay. Oh, go ahead.
So my first is a sort of a question / comment directed towards Nancy regarding bias. I understand the idea that if bias is, it's easier to correct for, but I think it's not a constant. Bias, I think, is going to still be quite complicated, including based on the location within the scan and even to an extent on the complexity of the nodule. So I'm a little concerned about how easy it is going to be to correct for bias when we really start getting down to fine measurements. And similarly, it's going to be different from scanner to scanner. So I just wanted you to comment on that a little bit. My concern, as I said, is it's a little more complex than just a number or a simple correction.
Sure. And I think I recognize that. I think that even happens with precision, like different scanners have different precisions, and it depends on different scanning parameters and locations and the type of the lesion, shape of it. So I think all those I recognize. But I can imagine building a statistical model, a fancy kind of regression model that takes all those factors into account, and so that I can estimate what the bias would be if you tell me the shape of the nodule and its density and its location and the scanner and the parameters. You tell me those things, and if I've had a decent data set to estimate the bias, I feel like I can estimate what that would be and make that correction. I don't know how practical that is, but it seems like that sort of thing is very doable.
Well, I look forward to working with you on that, Nancy.
Okay, great.
And I had a second question or comment to Steve Lamb. I want you to talk a little bit more about your determining biological aggressiveness or figuring out and what you meant by biological aggressiveness in the context of screening.
So the study I show is where Peng Wang used the NLST data with mortality outcome. So this is the endpoint. So you look at people who were found to have cancer that died from the lung cancer within a certain period of time. So you can actually, if you have 2 or more CT scan, one can identify those with tumor. They are very aggressive. The people who actually die within a short time. So perhaps those are the ones that have more frequent CT for screening to pick up this very aggressive tumor. On the other hand, they're a very slow growing tumor that people do not die for a long time. So those people may not require to have an annual CT to pick up those nodules. So that's what the study showed.
And you're predicting that? You're predicting who's going to have a slow grower and who's going to have a fast grower? Is that what you're saying?
That's right. Not just growing, but the tumor, the growth that will kill you. That's what it's supposed to show.
Okay, thank you.
Oh, okay. David, since you're on the screen right now, we covered 5 or 6 different areas of improvement for the small lung nodule profile. Do you have a favorite? Do you have a priority? Part solid nodules, accounting for bias, table phantom, CTLX2. I mean, there's and anything else that you might think of.
Oh my goodness. Well, I think I'm very enamored with the table phantom, that concept of continually correcting and continually monitoring scans for quality. I think if we're going to take this issue of quality seriously, which I think we're doing, and this idea that quality changes from location to location and it's influenced by patient factors, I think the table phantom becomes a high priority. I'm a little less concerned about those non-solid and part solid nodules, only because they're biologically less of a concern. You know, you don't lose a lot by missing growth in them. You know, it grew a little bit. You know, if you watch them reasonably carefully, they're not going to lead to death. You know, you can manage them, and you know the number of patients that die of non-solids is vanishingly small when you're following them on an annual basis. You can always, they never get out of the box. So to me, the focus should really be on the solid nodules, and if we're going to really start making progress in that area, I think, you know, the approach that KIBA has been taking, I think, is a really strong one. And starting to get these measurements and know when to do the repeat measurements. I think we're going to start to move much more into precision management based on our understanding of these measurements. I think the days of, you know, 6-month follow-up is the rule and 3-month follow-up is the rule. That's all going to change. As we get better and better at this, that's all going to change.
So how does the panel feel? Table phantom, should we head more earnestly in that direction? Sam?
I agree. The table phantom, I think, is a very clever idea that would allow for day-to-day, as David mentioned, evaluation and monitoring of image quality changes.
It's too bad we don't have Nick on the line, Nick Petrick, and you can tell us whether we can just deploy that. Anyway.
I'm here, actually.
Nick, if we tried to put a table phantom at the NIH Clinical Center, what would you have to say about that?
I mean, I think it would be fine. I think the struggle is to really get vendors to be interested in something like this. And again, you can obviously do it all on your own, but the more it was embedded in structure and generally available, I think the more likely it would be effective and people would take advantage of it. So, but I think it's a good idea to try it out, see if it works, try to distribute it, and then try to interest the vendors to get this as being more of a fundamental part of the system, because that really drives all the AI and everything else. You could take advantage of these measurements much more effectively.
Great.
Not a big expense here, so it's not something that should be, you know, completely limiting based on cost, but, you know, of course, the vendors have their own calculations of what's good or bad to put within their systems.
Yeah. Well, I think we can make a lot more progress on our own for a little while, and then if the vendors want to jump on, that would be great.
I agree. I think that's
oh, sorry, Rick. So we have a couple of questions that I think they are directly related, or they are targeting kind of a spatial resolution, no, as potentially the main property, you know, you wanna target in a small nodule profile. So Jim is bringing up the issue of ultra high resolution CT scanning that looks like might be around the corner based on the latest sort of scan technologies that are coming out. And George was making a very nice interpretation of Sam's presentation, in which he was looking at or asking if indeed keeping the field of view constant is indeed one of the primary factors to standardize the metric. No, and I think this is about how stable the resolution is, and also how best or better we can get, no, in achieving higher and higher resolution limits. And I think, Rick, your data in the past has shown how unstable, how spatially variant the resolution is. So I guess a general question to the panel is, should be resolution the primary goal to focus on? How can you achieve a much more homogeneous, better resolution performance? And is there ways to, both by, you know, new technologies or potentially post hoc ways to improve resolution? I mean, image deconvolution has been one of the primary image analysis techniques. Is used in astronomy. I mean, is what has allowed the discovery of black holes and so on. But that technology hasn't really brought, in a wide sense, brought into fields like, you know, medicine, or in this case, this application that to me looks like very much what we are trying to do. So what are the thoughts of the panel on that topic?
Well, if I can add in, the using 1012 by 1012 matrix is an excellent idea. The pixel size is going to be 1/4 of a 512 by 512 matrix. Only thing that we need to weigh in is the balance between resolution and the dose. When the pixel gets smaller, then obviously you need to increase the dose to keep the noise at an acceptable level. So it has to be a balance between achievable resolution, acceptable noise, and definitely acceptable dose.
That's a good point. Can I just throw out another concept, and that is that if you have a scan at time 1 with a certain resolution, and then you get a scan at time 2 with better resolution, that's not a bad thing. And David Yankelevitz has been saying that for a long time. So the problem is when you go the other direction, right? So we want to be careful not to tell everybody keep everything constant, when if they get a new scanner with better capabilities, we don't want them necessarily to give away that resolution. And resolution is not the only thing, but it is a major part of what we have. And with regard to, just lastly, with regard to deconvolution, it can only recover a small amount of additional resolution. It cannot, you can't create an image with no data, for example, or very little data. So unless it's highly constrained situation, but in a general sense, so it does have a role, but it cannot be it cannot recover major losses of resolution.
But can at least be used to standardize the metric, because that seems to be one of the targets. No, you want to chase precision, high precision, and definitely also high accuracy. But I think precision is one of the topics we are discussing and bringing up.
So
that could be a way to go.
Other panelists can join in, but but it can, yes, deconvolution and other methods can help standardize the imaging for quantitative analysis. But I don't know that there's an established standard for doing that. Other panelists know? It would have to take into account, Raul, you'd have to do a study where you allowed some variation in the acquisition system, including edge enhancement and other things, make sure that the deconvolution doesn't confound the signal because of these other features and artifacts within CT.
Yeah, I mean, I'm asking this because, and again, I don't want to overstep the panel, but we are doing, and other groups are doing work. And Marion, I think McCulloch just published a paper last year, I think, or even this year in medical physics, showing that in this case, through deep learning, you can take multiple reconstructions and then achieve a much more harmonious or standardized reconstruction with respect to the spatial characteristics. So there are, I think, post-acquisition methods. And in our group, one of our members is developing also harmonization techniques with respect to the spatial resolution, in both the density and spatial resolution. So I believe there are going to be interesting techniques that will, I agree with you, Rick, it's hard to recover or come up with better resolution. That is super resolution, and that is one topic. But the topic of can we standardize the spatial resolution of our CT scans? Maybe this is something, as people are starting to show, that can be done in a post hoc manner, in which obviously the phantom will be very helpful because can help probably to set up the params of those techniques. But with respect to the qualification, maybe those techniques are what might allow a potential scan to pass a qualification or not. So, you know, I wonder if obviously this is something that people had been somehow integrating, no? And how could potentially be the next steps of a profile like the KIBA profile with respect to these post hoc sort of recovering techniques that, as I said, is very promising, the data that is starting to appear in the literature.
Rick, I'm seeing in the chat box a couple of questions that are directed at your most recent comments.
I just dropped a comment in. Was there one in particular you wanted to discuss? We're almost, I think we're close to out of time, but.
Well, Sean had a question about balancing resolution and noise, maybe being using IR to offset the trade-off.
Yeah, so I did write something. Do you want to say something about that? Or?
No, I just wasn't it to you.
So
yeah, we haven't talked about IR yet, and it just seems like other kernels could be used, for example, to improve the spatial resolution that we already have in the images, given, you know, that we could go to a 1024 matrix.
So yeah, go ahead, Raj.
Just one point. With the existing scanner, using a smaller scan field of view would also give us a smaller pixel size. So that might be an option to consider with the existing scanners. Yep.
So it's interesting when we put together the COVID guidance, the question of iterative recon came up, and I thought I was alone in a little bit of concern about iterative reconstruction algorithms. If you notice, most people don't use them at their maximum; they only use them a little bit. And the reason why is because they do make changes all over that image, especially in small details. And we're just not confident that those changes are in the best interest of the measurement. So we're not totally confident. But with regard to a smaller lung nodule because of higher resolution, a good edge detection algorithm would account for that and put that edge in the right place, sub millimeter, sub voxel. So and we can get into the computer vision, but not on this call, not now. So.
Rick, there is a couple of questions from the audience that I think it will be.
Well, we're eating into our second panel time. So.
Yeah, I just you know, because I think it's nice to let you know the audience also to.
Yeah, go one more. Let's do one more, and then we'll move on.
Let's do one. So it related to Dr. Power was asking what is the suggestion of the opinion of the panel if the image quality is poor, no? How to handle that? What do you do? Do you throw everything down the drain, or do you truly have something you can do with that image?
Let the radiologist measure it.
You do the old-fashioned approach, no?
Well, look, I mean, there's certain examples like I gave with the spatial warping. We just would not tolerate that for measuring a nodule out in the periphery. So that's an example of it should never be used. I guess if you have it, you got to try and figure out whether a change is real or not, which is going to be very challenging. But for the other, all the gray area, we do have methods for helping sites determine. I mean, the KIBA small lung nodule profile and its calculator can give you bounds on the coefficient of variation and other things. So that will help you decide when to use it and when not to. All right, do we want to move on? It's actually, we're going to turn this over now to Raul for
Yes.
leading us through the next panel.
Yes, so we are moving on, I guess, expanding on this topic, and based on what we discussed this morning, we have a very lively discussion about how lung cancer screening can be a platform, not to truly characterize or intercept other diseases. So I guess the question now is how we can expand the protocol to truly address those other conditions, that we have been discussing. And we have a great panel with us today. We have my dear colleague and friend, Dr. Washko, that will do kind of an overview of this topic just to create, set the stage. And then we have Dr. Mario Castro that is joining us from Parma this evening, as well as Nick Petrick from the FDA, and Rick Avila, and I think Sean Fain, Dr. Sean Fain from Madison, Wisconsin, that he leads, is the chair of the lung densitometry KIBA profile, and he has been taking the lead of how to how to define or measure emphysema, what is the protocol, the right protocol to do that. And finally, we have also Dr. Javier Zulueta also joining us from Europe to comment on the practicalities, the potential practicalities, constraints that we might have developing a protocol like this. So with this, George, please feel free to take the stage and introduction.
Perfect. All right. Well, thank you very much, Raul, for the introduction, and thank you, Rick, Raul, and James, and everyone for the invitation to be part of the conference. I put together a few slides. If we can put those up there. It's a rather short slide deck. I wanted to, I think, get quickly to picking people's brains on the panel. Next slide, please. So my disclosures. Next slide. Perfect. So I think that a good place to start is really the question, why make progress? Why do this, right? Why do we harmonize a COPD and a nodule protocol? And this morning we've been talking a lot about all the information we can see on the CT scan. And so the first bullet point, is there clinically actionable data in the image outside of a lung nodule? I think it's an easy answer, yes, right? And the atlas to the right, the picture shows many of the comorbid conditions, the cachexia, the pulmonary hypertension, the cardiovascular disease, the osteoporosis. These are often undiagnosed conditions in smokers, the shared exposure with lung cancer. But then we get into a more nuanced discussion of, does a more precise assessment of those extranodular features truly improve care, right? How hard do we need to push to get this? And if the answer to that is yeah, then why isn't this done already, right? Next slide, please. So there's a ton of information on CT. Of course, as you see in the bottom left, we can look at the nodule, the surround, we can do radiomics and all sorts of analyses. But there's a lot of other big and telling organs evident in the chest. We have the heart, we have the vessels, we have the chest wall. We can look at cardiac morphology, RV, LV, dilation of chambers, coronary calcium. We can look at thoracic aortic calcium for atherosclerotic disease. We can look at the size of muscles, sarcopenia, the density of bones, osteopenia. These are very manageable conditions, right? And still, as of yet, we largely haven't fully leveraged this, but I would argue that these are bulk features that don't need a higher degree of precision in measurement than what we already afford through our LDCT protocols. The next slide. So what about the parenchyma, right? I think this is then the million-dollar question. And one of the underutilized opportunities in lung cancer screening is the ability to detect people who are candidates for procedures such as lung volume reduction. Lung volume reduction is one of the few disease-modifying therapies for people with COPD. Smoking cessation, oxygen therapy, and people that need it, and lung volume reduction affords a survival benefit in a subset of people. And that those criteria are defined in part by the radiologic appearance, severe emphysema and an upper lobe predominant distribution, such as what you see here. Now, to identify a patient like this, I would argue you don't need much more precision in your measures than what is afforded through a standard LDCT. Now, this is an older protocol that I took this image, and so newer technologies such as bronchoscopically deployed therapies require more data. We need to look at fissure integrity and other things like that. So I would argue, obviously, higher resolution we need for some of these features, but do we need truly continuous measures of things like parenchymal damage if that's what we're going to push for a better lung and nodule imaging protocol? Next slide, please. So, and we touched on this a little bit this morning. If we're going to push precision of our measures, if we're going to develop a common protocol, what do we gain from that? If I have continuous measures of emphysema, does it matter if in a cross-sectional study, meaning a first clinic visit or first point of contact, this person has 4, 6, 7, 8% emphysema? Am I going to modify my interventions? Now, maybe there is some threshold that we can actually define a clinical actionable point at which we've crossed. But beyond that, again, I'm not sure if continuous measures of disease afford us much. Now, you can turn around and say, well, what about in a repeat visit? You have continuity of care, a longitudinal assessment. I think this is where things actually become quite important. Now we're talking about the true progression of disease. And I think when focused on emphysema, we can enable clinical trials, we can measure disease activity. Imagine if we know if someone is a rapid or slow progressor, and we saw a little bit of that in Jerry Kreiner's presentation this morning. We can monitor a response to therapeutic intervention if we had one. And indeed, even this continuous measures may have some bearing on cancer risk longitudinally. We now believe that the emphysema is associated with increased risk of lung cancer. Does the more rapid progression of emphysema also increase the risk of lung cancer? Is unexplored, but is an interesting question, right, as sort of a one-off. The big limitation to all of this, and I think we need to consider as we're allocating our energies, is that we don't have a therapy to offer for progressive emphysema. We can certainly get people in a clinic, we can practice good behaviors, right, smoking cessation, vaccinations, we can do these things, pulmonary rehabilitation of those that need it, but we have no direct therapeutic, and we've been captured to a degree in a circular argument of we don't have a therapy because we don't have a biomarker, because we don't have a biomarker because we don't have a therapy, and how paralyzed should we be by that, or should we just do something? And so for this, I said I would label this as being an aspirational, and I know Barry Make was using that same word this morning as far as how we dedicate our energies or what we think about this effort. Next slide. There are, however, other manifestations of parenchymal injury in the lung of smokers, right? Emphysema involves generally a loss of tissue, whereas interstitial lung disease, interstitial fibrosis, is generally a gain of tissue. And here's examples. 3 panels in the left column are baseline, and then the follow-up images on the right. This is someone that has progressive interstitial changes on CT, and based upon the pattern, these are progressive fibrotic changes to the lung parenchyma. Next slide. These are generally what we call ILA, or interstitial lung abnormalities, and they are truly biologically distinct from emphysema, but highly clinically relevant. 6 to 8% of the people over the age of 50 have them. In a subset of people, they represent early and potentially progressive fibrotic lung disease. The presence is independently associated with all-cause and respiratory-specific mortality. They're associated with worsened respiratory symptoms and poorer exercise capacity. And we actually have therapies for progressive fibrotic lung disease. We have nintedanib and pirfenidone. They are on the market. And so maybe we should pivot or allow some focus to bleed over into looking at the other form of parenchymal injury that is maybe slightly more dynamic than emphysema, because that's also a very slow growing process. But this is potentially more modifiable in the short term. And I would argue that we want an underhand pitch. We want to hit, we want to get on base. We want to hit a home run. We need some energy to do this. And so I call this the actionable direction for now. Next slide. And so in summary, I think we'd all agree, there's a high degree of concordance. There's clinically useful data in the lung cancer screening CTs. I would argue that the heterogeneous, and they're not so heterogeneous, but we'll say mildly heterogeneous protocols are okay for a lot of the comorbid disease conditions that are present. And I think even for detecting emphysema as a binary or a categorical, be it semi-objective or objective. And the common lung and the nodule protocol will enable emphysema treatment. But again, that's aspirational. We've been waiting a heck of a long time. We've been going to these conferences for a number of years, waiting for pharma to come with that drug. And I think we have to keep chasing this, but why don't we also think about other forms of parenchymal injury where therapies are ready for prime time? So I'll stop there and certainly open it up to the panel of experts.
Thank you, George. Thank you for, I think, putting some interesting thoughts out there. So now I guess we are going to let our panel to provide some insight, and then we can have a discussion. Just very briefly, my apologies. I believe I introduced Dr. Silva as Mario Castro, another very important Mario out there, but Dr. Mario Silva is with us today. And also I forgot to introduce that he doesn't need an introduction, Dr. Yankelevich. So, okay, so now that we have all the panel with the names straight for the record, please, I will let you on.
I thought I got lucky.
Yeah, no, you are not of this. You know that. Jim will let you. Dr. Fain, please, if you want to start with your opinion, I think you have a few slides you want to share with us.
Yeah, I had a subset of slides on the lung density profile. Okay, great, thanks. Yeah, I wanted to just add to what Dr. Washko presented in light of our focus on developing a profile for quantitative lung density measurement as part of the KIBA effort. We had to address a couple of important questions, one of which that hasn't really been addressed yet is the issue of lung inflation. And because we're interested in looking at parenchymal density, the inflation state of the lung is an important parameter that certainly affects our measurements. And so I think one issue to maybe point out is how important it is to develop consistency of coaching for respiratory maneuvers in light of our interest in quantitative lung. With proper coaching, though, it's certainly feasible and has been shown in larger studies like COPD gene that we can track progression of emphysema. And that's, I don't know if you're able to see my mouse at all, but if you're looking at the lower left panel, this is a baseline and a 5-year follow-up. So that's certainly feasible. And then regarding the issue of IR specifically, we've been able to, at least in sub-studies, show that we've been keeping our measurements consistent, both in terms of bias and precision, at least over the whole lung in comparing a conventional dose and low dose protocol through the use of iterative reconstruction to help mitigate noise. There are other approaches to this, for example, to look at median filtering and more conventional methods that don't depend on IR. But I think there are solutions for the low dose implementation. How do I advance slides? Anyone help me there? Thanks. The other point I wanted to make about the profile, and this is very germane to what we discussed with respect to volumetry, is that in our design of the profile, we maintained demands and specifications for high resolution. And so obtaining both is possible to obtain both quantitative parenchymal density measurements and isotropic resolutions of 0.5 to 0.7 millimeters to support airway geometry measurements. And so we've deliberately built that into the development of the profile, and I think it nicely aligns with the overall discussions we've been having, that balancing both resolution and quantitative parenchymal density is possible, and indeed the ability to make multiple measurements from a single quantitative CT scan is feasible. And then if I could get someone to change the slide again, thanks. So I just wanted to make just summaries of what I just said about development of the KIBA profile, by the way, is now at the public comment phase. Actually, we just got through that. So we now have a mature profile that we're going to develop for field testing. And that profile enables us to do both quantitative parenchymal density measurements and high resolution for airway measurements. And then we've been really emphasizing and exploring low-dose protocols. And I really think that's an important area, and the IR piece of that is critical, and in fact is going to be implemented whether we have a profile that supports it yet or not, mainly because of the drive to lower dose for longitudinal CT studies. So it's an important new area to talk about. And then just the upshot is I think this, we're at a point where the standardization of high resolution quantitative CT protocols in the lungs is opening up the door to multi-parametric studies. And I think that's an important area for us to discuss. Thanks.
Thank you, Sean. So Dr. Bedrick, any thoughts, or I don't know if you have any slides?
Yeah, I think should have a couple slides if they're there. They're quite basic. Next slide. So just a couple, I mean, I'll just give sort of a technical view of what to think about, I guess, or what I was thinking about when thinking about what I call multitask protocols. And I think the first question, there's just a couple of things that probably you need to think about before you get too far down the pathway, is sort of what are the clinical questions you want to solve. And as you said, CT has a huge amount of information on it. You can look for all kinds of things. I think you really need to decide, or the team who's going to put this together, what is the real core functions that you want to look at here before you get too far down the pathway of how to develop this protocol or what it should look like. And so those could be the COPD conditions. There may be differences when you look at the lung nodule side of different things you want to be able to measure or do. There are things that may be joined between the two, which of course makes it easier because you're going to do one single protocol. And then are you doing things that are new, or are you doing research types of exploration? So is emphysema for a clinical application, or is it for a research application, or any other measurement you're thinking about making? I just would caution though, because there's so much information on CT, there's also the ability to do overdiagnosis, that you end up looking for things and finding things that exist, they're real, but are they really clinically meaningful and important? And sometimes they are, and clearly they're good things to measure. Sometimes we just don't know, and we need to do studies to figure those out. And other times they're really not going to be that helpful, and they'll just cause more problems that then are probably worth trying to measure them and understand them. The second area, just on the clinical side, again, are these real world clinical applications that are going to be implemented in real time? Clinicians will be able to use them quickly, or are they sort of more researchy and looking for future direction where people might use them in the future? The other aspect I would say is important is to contemplate what are the quantitative measurements that you're trying to accommodate. So beyond the clinical test, what are the measurements now that you're trying to make on those studies? And understanding this will help again to decide what type of protocol do you need here. So is it a set of relatively limited number of well-defined measurements that we can understand and know how to implement? Or are they something like a radiomic approach where you might have hundreds or thousands of potential measurements that you're trying to integrate into an analysis of the patient in some holistic way, or particular to lung cancer or COPD or whatever the aspects might be, or are they combined together? Or we do have a deep learning approach where we're not going to actually deal with actual particular features per se, but we're going to try to determine, again, some sort of outcome type of metric, whether that's, is a patient have lung cancer? Is this a lung nodule? Are these areas of emphysema? Is there fibrosis here, or something along those lines? So those have different aspects to the conditions or the information you might need, and the ability for things like deep learning to accommodate variations in protocol and parameters that might make it a little bit more robust, but again, may also cause it to be a little bit more fragile in the sense that it may fail in conditions where you're not really expecting it to. Next slide. So once you do that, I think then you can start to think about the technical implementation issues. And again, I'm thinking more on the imaging side here. So you want to try to define the imaging requirements for that. Obviously, answering the questions on the previous slide is going to help to set that up, to either understand what specifically do we need to make of those requirements, or are there areas that we need additional study to try to understand those protocol requirements. The other thing is it going to be driven more by, say, the COPD need or for the lung nodule need? It most likely will, I would think, be driven more by the COPD need. So in some sense, having a good COPD type of protocol probably is going to work fine for lung nodules, beyond the issue of things like dose and so forth, and practical considerations of what's viable and what's reasonable for each of these different aspects. And then finally, to think about the QA/QC requirements and what do you need in the physics measurement side of things? What are things that are relatively straightforward to implement and do? What type of phantom measurements or phantoms do you need within the study protocols? And then also thinking about the user training. What do people need that are utilizing either the tools or in the clinical context for utilizing this information in these scans? Because you could produce scans that are quite good for quantification, as Sean was talking about using IR, but are those the scans that people are going to want to read in a clinical context, or do you need multiple sets of scans? So that's sort of what I just wanted to lay out there from a technical perspective. Thanks.
Well, thank you. I think this is really interesting, challenging questions, I guess, could be even for this panel or the rest of the members. So Dr. Silva, any thoughts, any reactions to the questions that Dr. Patrick just posed?
Oh, hi. Thank you. Thank you for the opportunity to be here in this international room today. Thank you, Raul and Rick, for this. I'm a chest radiologist. I have a background experience in collecting data for lung cancer screening. So I'm a bit aware of the nightmare of measuring these nodules. And luckily now I'm in the side of project development of this projects and protocols of CT, and I'm lucky enough to be involved with Rick in the small lung nodule group of KIBA. So during this panel, I think we pose a couple of questions. First, which are the challenges and opportunities of a coupled COPD and nodule protocol for when you do lung cancer screening with CT. And the second question is how we can disseminate and achieve acceptance of such protocol that we might be interested in developing. So first question actually is really intriguing because the combined oncologic and functional screening is really appreciated. But we know, and Professor Washko mentioned before, sometimes when we rate emphysema as a component of COPD, we're actually doing a rather intellectual exercise. If we think that these people that undergo lung cancer screening are actually in a relatively good function, so action on that emphysema is not really a priority in that very moment. And we'll get back to this point a bit later. Maybe we might focus our protocol more on the side of chronic bronchitis. And this bronchial characterization, we are aware it's not that easy to pick up on this kind of test for several reasons. First of all, the degree of inspiration is not always the same. So a way to standardize inspiration would be needed. There have been several efforts. I think this effort started when I was in primary school, and we're still going on with this kind of development. So first of all is that. Second thing, when we evaluate bronchi, we know bronchi in summertime, bronchi in fall, those are changes that might impact on the quantification of bronchi. Still, chronic bronchitis is something that people undergoing screening might have, and might have in some kind of severe way. So this, I think, should be a topic to pinpoint on our short list for coupling oncologic and functional imaging in lung cancer screening. I agree, emphysema, yeah, it's nice to, it's easy somehow to detect and nice to detect, but it's for these kind of people, we require a lot of time before we have to take action. And to date, we do not have therapy to prevent evolution of emphysema. On the other hand, if we track bronchial abnormalities, not just thickening of the bronchi, maybe those signs of chronic bronchial inflammation, like diverticuli, well, that might be some kind of more factual representation that might help us to take action on this chronic situation, maybe with drugs, but also maybe just with the person that might be more convinced and stopping smoking. And there was this discussion on the previous sessions that usually emphysema is so low that people might be actually more encouraged to keep smoking. Well, of course, we don't have to tell people that are smoking that smoking is not causing damage to their lung, but when we see some kind of damage, we might be allowed to tell them that there is still space to stop this trajectory, I would say. So we can, with screening, basically we can track trajectories along the functional development of these diseases, and this is why I think this protocols should indeed point at a stable quantification of the parenchyma and bronchi in the long run. So we're now doing lung cancer screening for cancer. The run of a cancer is much shorter than the run of a functional disease. Also, we've heard about ILA. That's another big chapter. So I think this these profiles and protocols should be adapted to the long run of the disease that we are going to tackle. And for this reason, and for several reasons, technology is moving very fast. I think density would be no more the target here. We should rely on something that is more complex, and maybe leaving density apart, or maybe on the second floor would be maybe a good perspective to move forward and really do something for functional evolution. Also, because if we rely on density, we know that today CTs can do low dose with different filtering of the beam, so we can have different signal perceived to the detector, and we can have different algorithm for reconstructions and several things going on that change every other day. And these are proprietary algorithms and devices for each vendor. And of course, this is made in the interest of dose, and of the radiation dose, which can be reduced when we look at a very small finding, like a nodule, usually a solid nodule, but the radiation dose is actually bad for a compromise when we evaluate a diffuse lung abnormality with a mild change in density. Second question that we might have is dissemination and achievement of acceptance for these profiles. Well, I'll be much shorter here. I think we have to fill in the gap. So as alliance, the KIBA is an alliance that is composed by several specialists and technologists and this kind of things. We have to be up to date with the evolving of technology and CT scanners, and also software development, because that is going to make the difference in what other entities that, for instance, NHS England already has recommendation for that. Why should they be following KIBA? Well, because KIBA is given an answer to those things that NHS England cannot say. And one thing is maybe updated standard of reference for this or the other thing, or just saying what we can or we cannot say on CT. Today, in 1 month, and maybe have an update in the next 6 months. So sorry for not having the slides, but I thought I could talk also in person and we're not in the same room, but at least seeing our face might make it a bit more pleasant. Thank you.
Yeah, absolutely. Thank you so much. I mean, I think these are great topics, and what I took away from listening to you is that maybe maybe we should open the door to an expiratory scan. If obviously densitometry is probably too much of a low bar, and maybe the true benefit is by looking into this more kind of obstruction airway component of the disease. Clearly, that has some implications protocol-wise in that. So I wonder, with that being said, I wonder if next Dr. Yankelevich could bring his wisdom to shed light into this, because it's not an easy. Now we are talking from one. Let's do inspiration. Let's try to control the inspiratory effort. To maybe, hey, let's keep adding. Inspiratory, expiratory, because we want to do all these things. What are your thoughts?
Well, I have a few thoughts on this that I'd like to share with the group. First, I agree with the idea of doing it face-to-face, although I'm not sure my face is as appealing as yours, Mario, but I'll try my best. I've listened to the sessions from this morning and now, and my first observation is I'm feeling a little bad for my pulmonary colleagues. They seem to be a bit frustrated with the direction of emphysema and the lack of, finding a good treatment. That's come across a bit in the discussion. So, I was taken by the comment of, George, where we really was saying, let's just kind of move into big buckets and, whatever your categories are, but the idea of really getting a continuous scale seemed to be less important. I'm not sure about that, but, that has a lot of implications, and so I'm sort of echoing a little bit, I guess, what Nick said, although I have a different take on it. The idea of that should drive your protocol. If you're thinking about building a protocol, then if it's just big categories, then you get that from today's CT screening scans. That's it. We don't need any. If that's your view, then it's done. The current protocols for imaging for small nodules give you everything. Now, I don't really believe that, but I think that's the implication of that idea. And I'm not going to be the one to solve the issue of whether there's a future for treatment of emphysema, but I really do think, when I look back at the nodule profiles and whatnot, 1 millimeter, when we made a change in 1 millimeter for the size of nodules for different thresholds, that was like, a major change. We moved from 5 millimeters to 6 millimeters, we reduced false positives by 20%. And, I suspect that we're still there's going to be a lot of value in being able to quantify the extent of emphysema. And I especially think this is going to be important because our focus has been on all this late emphysema. I think when we really start focusing now on earlier and earlier disease, I think there's going to be more meaningful therapeutics. And we have to, I still think our understanding of the natural course of early emphysema is pretty limited. And I think that's where there's going to be some action. So I do think we're going to need to still be able to quantify things. My next thought about the overall process is, when you build a combined protocol, I think you're going to do one scan. We're not going to be able to do more than one scan. We can do lots of reconstructions if we want to. And certainly I've heard from Tony Reeves endlessly how iterative reconstruction is not helpful for the image processor. They want as unvarnished an image as they can possibly have. And so I think the idea of multiple series for this is really important. The issues of looking for ILD or findings of interstitial lung abnormalities, bronchial wall thickness, all of these things are high quality measurements. And so you're getting back into the domain, similarly with small vessels, where you're looking to see all of this is sort of analogous to what you're going to want in a small nodule profile. You want to be able to measure small, subtle changes. So I think those protocols, that overlaps. The idea of separating completely, the idea of a density protocol is something sort of different than a protocol for nodule. Rick, you should comment on this in a moment. I don't think they're independent. I think, if you have problems or inconsistencies in your density, that's going to affect all your anatomic measurements as well. These are all linked in complex ways. So I think that that's another consideration. And my other thought on this was, you're going to want one calibration device. You're not going to want two. At some point, we've got to figure out a way that we calibrate in one shot. And I love the idea of the table phantom being able to do everything. You're going to be able to get density and spatial features, so you can understand that. Just to comment, physiologic measurement, an expiration scan, it adds a lot of information. We know that, and I guess we have to get our pulmonologists to say that it's important. I mean, if and so George, you're going to have to comment. I mean, I'm is it important to know that, hey, there is more obstructive disease there, or are you going to tell me that, oh, just get a spirometry and you're done? So anyway, these things all interact. There's all feedback here. I personally believe that, we're going to learn how to use this quantitative information. We're literally just starting to learn how to use it with volumetric data for lung nodules. And we've been at this for over, how many years, Rick? Since we did it with GE, it's like 20 years that we've been at it. And it's just starting to get meaningful now. People are just really starting to use it. And I suspect that's what's going to happen with emphysema. So I'm giving you a pep talk, George. I do think we're going to find a lot more valuable information here, and we're going to be able to translate this into very meaningful patient care. That's my comments.
Well, thank you, David. I think it's, in all researchers, we like to keep on making problems, no, because it's how we survive. So I think you never want to solve a problem. No, that is for sure, and for survivals. But I think I take some interesting point, or I see some interesting point in your talk, that is maybe this one of, are we already there maybe? I mean, do we need a joint protocol? And then I turn to you, Javier, because I think you and your group had published extensively in the interplay between emphysema and lung cancer, and the utilization, or how useful and valuable that information is. Using your lung cancer screening program, no? You didn't change protocols, you didn't modify, I think, anything. So I guess my comments to you is, do you think we have all we need, or do we need more? Do you think something would have changed? Do you think your results would have changed had you have maybe a different protocol, as we are discussing now? And maybe I know, maybe you want, some of the technicalities are not, they can get very complex, but what is your sense?
Yes, thank you. Well, first of all, let me thank David, as a pulmonologist myself, for feeling our pain. I appreciate that. Yeah, Raul, probably not much would have changed in what we have done, but our protocol was a poor man's quantification of emphysema. We just look at it and say, hey, there's emphysema, that's it. And that was good enough for the purpose of what we found, which is to predict risk of lung cancer. But which is, I think, very important. And actually, I would use that to argue against the concept that, since we don't have anything we could do for early emphysema or asymptomatic emphysema, we shouldn't really worry about it. And, we, in our clinic, in our screening clinic, we use it quite a bit. I look at the CT scan with the patient and I show what emphysema is, and I can tell you that has an impact. And so right from that moment, there's a lot of things that I'm doing for that patient just because of the information that I'm providing. The fact that the patient has emphysema might encourage that patient to quit smoking more, do exercise, blah, blah, blah. Plus, we will have therapeutics. And as David was just saying, as we get better and as we are able to quantify progression in short term, not because emphysema progresses very slowly, that would help and encourage the pharmaceutical industry to jump in and provide, or at least to research therapies for early disease. So I think it is very important. But there's another unexplored area, which is diagnosing COPD with CT scan. I'm not going to go into the interstitial lung disease. I think George already made a very nice presentation about that, and we already have medications that we can use. But 5 years ago, we didn't have those medications, and that, I think, didn't discourage people to look at how CT scan, how you can quantify interstitial lung disease. And now we have both. We have the tool and we have the medication. So that's wonderful. And I think the same thing might and should happen, I hope happens, with COPD and other lung diseases. In the case of COPD, let me, we do spirometry on all our screening individuals, the patients who are undergoing screening. And we find that 30% of the participants in our program have COPD by spirometric criteria. 30%, that has been confirmed by other groups. In Pittsburgh, they found 40-some%. And in others, they found even higher. Leahy, we saw today, 50-some% emphysema. That information is amazing because COPD is one of the most underdiagnosed diseases there is. I mean, 10% of the population. This has been corroborated by several studies. 10% of the adult population has COPD by definition, by spirometric definition. And we only know about the tip of the iceberg. Now, USPSTF says don't do anything to uncover that unknown COPD because we don't have any treatment for it. I have a tough time accepting that. I want to know that that patient has COPD. First of all, I know that that patient has a very high risk of lung cancer, higher than the same amount of smoking without COPD. So they say that we don't have any intervention that could reduce mortality or help outcomes in patients with COPD. I would say, yes, we do. We can encourage those people to undergo lung cancer screening because those people are probably going to benefit most from lung cancer screening. So, I think for the CT scan, if I can ever get the information from the CT scan about the presence of COPD and the severity of COPD without doing a spirometry, that's going to help every screening program around the world to do the same thing that we're doing. We're doing it with spirometry, and I think it's very, very useful information. So I would encourage you guys to develop these protocols because they're very helpful. Now, there's the question, we're overwhelming primary care physicians and other providers with information they don't know what to do with. Well, we have to educate them. I mean, I didn't know, if I do a screening CT and they tell me that there's this lesion under the diaphragm, I go to my next door to my liver specialist or whoever knows about this. We'll educate these physicians. We don't have to not know something because we don't know what to do with it. We have to learn about it. And I think it's our mission to teach and to educate providers on what to do with these findings. So I would encourage, and I agree with what David said, I think we're just starting, we're learning, and we're going to go on and develop and have amazing tools to do research. And we're going to, in the meantime, uncover a huge amount of individuals with COPD that we're going to help them from a clinical point of view, but we're also going to have a beautiful cohort of people that are going to help us develop all these treatments that we really need for early disease. And probably and hopefully we will be able to do what the cardiologists do, which is stop the disease early. So we have the tools. We need you guys to develop the refinement, to develop the protocols to help us start the trials and get that information. So I'll leave it at that and maybe we can continue the discussion.
Yeah, thank you, Javier. So I guess now we can open the panel for discussion.
Raul, can I start off with a question along the lines of what Javier said? If there was a tool that showed progression, whatever, change in emphysema, even though there isn't a pharmacological therapy, I thought that there's a lot of potential occupational and other exposures that could be contributing to the progression of COPD. Would not a physician with the information and the patient with the information saying that this is progressing, and it looks like what your work in a coal mine or your work with chlorine or your work with whatever is contributing to this progression, would that not be a valid use of such a tool? That's for George.
I was looking at Javier. So go that way, go that. It's a great question. I think that the big challenge is that these are sort of multi-exposure etiologies, right? So how do we associate exposure with outcome here? There are people who don't work in dusty jobs, who don't smoke, who still develop emphysema. And are they now turning around and saying, well, is it the insulation in my home? Is it my proximity to a major roadway? So there is the imprecision in the association. Look, I don't disagree with educating people or empowering people. I think this work has to be done. It's maybe coming back to, and Javier brought up the good point of we bring a lot of information from this, and we need to be prepared to deal with it, right? Especially now in the world of the EHR, anyone can log on and look at their radiologist report and see of all these things, and then the next half hour of your 31-minute follow-up visit is spent reviewing the CT report. So it's obviously, simply because we don't know what to do with it doesn't mean we shouldn't look for it. I 100% agree. It's just how do we manage things?
Right. Okay. So Raul, sorry, I threw in my question. Go ahead, please.
No. I mean, please, we are open for questions. And before I take questions from the audience, indeed, Dr. Charles Hatt, that is very involved also with KIBA, has, I think, a very interesting question. But maybe something that I want to put on the table for the audience, thinking of, should we develop kind of a new common profile? I mean, I guess it's very clear the benefit, in my opinion. The question is, when bringing this towards the development of a new profile, or a new protocol, I should say, a new imaging protocol around lung cancer and COPD, in my opinion, is, do we have to think of COPD as a comorbidity, or are we thinking about COPD as the central target of this protocol? Because I think modulates what we do and how we are approaching this problem. And I think I can see here both camps. George thinking of COPD maybe as a much more of a central disease, and then Javier was thinking of COPD or emphysema as one of the comorbidities that obviously modulates how you assess lung cancer risk. So I think setting that, and I guess trying to then maybe hoping if the panel could comment, I want to also bring to the stage the question that Chag is putting, that is, should we just use deep learning as a binary classifier? So rather than a continuous metric that is definitely much more, I guess, difficult to achieve or to qualify, even has its own complexities, could be enough to flag COPD, yes or no? No, that is, I think it speaks to what I was commenting on. Do we think of COPD as a comorbidity and design around this, or do we think of COPD as the central core of what we are trying to do? So I don't know, anyone wants to take on?
Let me just answer.
Oh, okay.
No, sorry, I just wanted to answer or clarify, I think what I said. I don't mean to say that today, COPD should be considered just a comorbidity, and we should use it for risk profiling to individuals. What I'm saying is that today, that's what we know about information on CT. We know that if we see emphysema, we can predict a higher risk of lung cancer. But my aspiration is to continue to learn on that information in order to intercept early disease, early COPD, early fibrosis, et cetera. So please don't understand that I'm just thinking COPD as a parallel secondary finding. No, I think it's lung cancer and COPD are in the top 3 causes of death. So it is an important disease we have to address, obviously.
Dr. Molsheim brought up the idea of a follow-up CT that would focus on lung function if emphysema or COPD-based measures were present in the lung cancer screening CT. And I guess I also was thinking about Dr. Silva's comments about the timescale of the disease process driving the motivation of what type of measurement to emphasize. And I think that's a great point, actually. And the role of function in COPD thus far has been, by focusing on emphysema, has been focusing on a long-term disease process. But I don't think that's necessary, actually. I think that the ability to maybe combine, say, air trapping and emphysema and airway markers, probably with lung cancer, could help assess disease stability on a shorter time scale, right? And that could motivate your therapy approach for that patient, I would think.
In addition to that, I would add that when we think about, as we stand today, when we think about emphysema or protocols for emphysema, if you have to change them, we're just using the regular CT scan, obviously, but if you're going to develop, you've talked about this 2 different protocols, you have to understand that maybe we're talking about 2 instances in the lifetime of a screening program. That's the baseline scanner, which you might want to know a little more about COPD, emphysema, et cetera. But you don't have to do that annually in terms of diagnosing new COPD or new emphysema. I mean, you already have that information. So, I don't know if this makes sense, but I know David was saying that you only need 1 protocol, but maybe you do have a special protocol for the baseline round, and then, annual screening, you do something differently. I don't know if that makes sense.
Yeah, and I think this speaks to what George was commenting on, that because maybe there is lack of therapies around emphysema, the assessment of progression maybe is not a requirement, that should be put on the table when designing a protocol, because that brings, I guess that is some of the complexities the KIBA, the lung densitometry KIBA profile was trying to address with. And indeed, that specific comment is, and maybe I didn't choose the right terminology, and I think of the nomenclature as Dr. Celli was commenting this morning, but that is what I was referring to, what I was thinking of, or I was throwing the term of comorbidity, we want to do sort of a primary characterization of the disease, but maybe the intent is not to maybe define all the axes of the disease, and obviously that, as I said, that I think has implications in how we develop potentially, a protocol is being developed. So maybe we have only a few minutes. I guess I want to just get from the panel maybe a summary statement going to the core question, like what is then, from all we have heard, I think, can we agree on the need of maybe of a refined protocol, and what will be in your opinion, maybe the most pressing element you will want to tackle as part of that protocol? You want to, bootstrap the protocol for emphysema, as we discussed. We want to bootstrap for some of the airway conditions. Do we want to just qualify what we have and define as Dr. Celli was proposing? Give me a standardized thresholds and I'm okay with it.
Well, Raul, what's the difference between the protocols now? I mean, why don't you say, what's the major difference really between them right now? Are they irreconcilable? Are they so different? I mean, to me, probably one of the maybe the issue is noise, for example, is probably the biggest issue. And so you're using a slightly higher dose for the densitometry kind of protocol. That's probably the biggest difference that, at least that I'm aware of. That shouldn't be that hard to reconcile. So long as you feel it's worth making a better density measurement, you know.
But David,
I'm okay with raising the dose on the
David, well, if we, so a lot of the, I think the lung density protocol recommends, is it 0.5 millimeter or sub 1 less than 1 millimeter? Is that right?
So 0.5 millimeter to 0.7 millimeters for airways.
So,
yeah.
So just David, imagine we said to all lung cancer screening sites, you really shouldn't be doing any scanning under over 1/2 millimeter. Yes. Obviously, there's going to be pushback on that.
Yes. There would be pushback, but don't you and I both agree that we'd love to see them obtain the images with that quality and then reconstruct it in other series, whatever they want?
I agree. It's just that I know of the 20 or 30% who will just throw the whole thing out.
Yeah, but you're letting reality sway you.
Okay, all right.
The other reason for a possible follow-up from functional would be to have the ability to do multiple inflation states, because I think air trapping measurements are going to be really important in early disease progression in COPD. And so having the option to do an RV lung volume in addition to the TLC lung volume, I think would be the real strength of a functional, CT protocol focus.
And that Sean, is a great lead into a comment by Dr. Stephen Lamb on the chat. And I'm going to read it as my final comment. And I appreciate that he did this. He says that even though we don't have treatment for early emphysema, airflow obstruction can be treated for symptomatic relief, reduced exacerbation, and hospital admissions. But focusing on CT changes that correlate with lung function would seem to have a bigger clinical application. I agree 100%. And I think that should encourage us to pursue this.
So it's 3:16. Do you all want to continue, or can we continue, or do we have to close here?
Well, I think it has been a long day for sure.
I need to just say a couple things before we close.
Yeah, let's, please wrap up, Rick.
On this particular topic of a combined lung cancer or lung screening and at least emphysema protocol, we're going to continue to meet, just like we did for the guidance that we put together for COVID. And we'll probably do it through, let's just say we'll do it through KIBA. So if you'd like to be involved in that, I highly recommend you send me and Raul an email, and we'll pull you into those meetings as they form. We'd like to get the COVID document sort of out the door, but it's okay to have a little bit of overlap. So expect that to happen. Our first task, which we've made a lot of progress with here, is going to make sure we assign the clinical scope of a combined protocol. We define it relatively early. It can be, as we've discussed, research. It can be to just move the field forward, but also looking at things like fibrotic disease and assessing risk for lung cancer and other things. So expect more to come on that, and we'll meet on that. Lastly, I just want to point out that there are still a lot of opportunities here. If we do push the envelope with calibration phantoms, imagine that algorithms now have in the DICOM header for every slice information about the independently measured noise, the CT linearity curves, the resolution, the other things. So even if you're trying to measure emphysema up in the apex, where you're going to have a lot more noise and beam hardening and other things, you at least have some more information about the fundamental, basically, properties of that acquisition. So I just want to leave you with that. I think there's a lot of opportunity there. Raul, please close us up.
Well, I think I couldn't close this in a best way with those comments, and I just maybe want to thank everybody in these amazing panels that we had. Thank you for facilitating such a insightful discussion. So I guess now back to you, Jim, if you want to do final closing remarks.
I'm happy to close up, but I want to just make sure. Al, I don't know if you're still online or you can talk to us, but do you have any final comments? Pardon? Okay. This has been a very, very important day in my estimation. I think it's been very productive. It's great how you've been able to stream things from the clinical to the technical and have so much apparent buy-in and common upside. I would second Rick's recommendation, and I have a little different motivation. In working through a KIBA profile, which is great, the goal line keeps moving because there's we keep learning more and stuff like that. Both the small nodule and the density profile are on a path, and I don't want to pull them off that path at all. I think if we have a bridging document such as Rick defines, that kind of says why we're doing what we're doing and what we're doing and what the implications are and stuff like that, we can make simple modifications to our existing profiles and keep going and not lose any time. And we'll have this other publication to kind of let the rest of the world see what we're up to. And then we'll have complementarity that we can maintain over time going forward. Because this dialogue has to continue. There's lots of issues and there's lots of new opportunities. I just want to point out one thing that wasn't covered today. The CANTOS study, cardiology study, statin-resistant atherosclerotic disease. They do a big phase 3 trial. This is Novartis, published in New England Journal, and they have statistically very significant improvement in cardiovascular endpoints. Take the same database, look at for lung cancer endpoints, because the experimental tool here is an IL-1 beta antibody that neutralizes IL-1 beta activation in an immune cascade. And so it turns out that this drug that reduces cardiovascular risk, reduces lung cancer risk, mortality by 45%. This week in Annals of Internal Medicine, that same data set was then analyzed, and it turns out it reduces osteoarthritis of hip and knee by, again, about 45%. Now I'm scratching my head. I'm waiting to hear the shoe drop on what this blockade of IL-1 beta does to obstructive pulmonary lung disease and other inflammatory diseases of the lung. And I gotta believe it's gonna do something. And this is just the first of many immune-directed drugs that potentially will have a benefit in this space. And if we work out the precise conditions to do change over time for a variety of these signatures we've been discussing, we will accelerate drug development in this space dramatically, and we will do patients a big favor. So I congratulate everybody for their involvement today. It's important, and let's keep going. Thank you very much. Thanks both to the Prevent Cancer Foundation and for the American Lung Association for making this day possible. It's great. Thank you.